Time to get started. My name's Dr. Emily. I'm one of the co-creators here at NCLEX Bootcamp, and we have another of our creators in the chat moderating. I'm able to see your comments coming through, but there is a little bit of a delay, so I'm not ignoring you. Between me and her, we're going to be able to get to all of your questions today. So, all right, I am so excited to be talking to you about what's on the next generation NCLEX. And we're first going to look at the purpose of the NCLEX, because that's going to help you understand why this material is on there. We're going to look at the top 5 client need areas on the NCLEX. And then we're going to spend most of our time going over some live practice questions of the top NCLEX content area. So, all right, first, what's the purpose of the NCLEX? And how many of you guys have heard someone say that the NCLEX is a safety exam? Who's heard somebody say that? And I think we all have, right? Because ultimately it is true. While your purpose for taking the NCLEX might be to protect the public, the ultimate goal of the NCLEX is actually to the actual goal of the NCLEX is going to be to make sure that you are going to be a safe entry-level nurse. And so in order to do that, they determine with a 95% confidence interval that you're going to be a safe entry-level nurse. That's what it means when you've passed the NCLEX. And remember, this is going to be an entry-level nurse, not a very experienced nurse, not a specialist nurse with 10 years of experience. So they're going to ask you these really big picture, safety-focused questions. And that's what we're all about here at NCLEX Bootcamp, is making sure that we're asking you the most important things that you're actually likely to see on the NCLEX. We're not going to waste your time with stuff that's super detailed or super advanced, but just the really important stuff. Give me just a moment here. So, all right, what topics are on the test then to determine that somebody is a safe practicing nurse? So every 3 years, the NCLEX actually sends a practice analysis survey. And in that survey, they ask nurses, what in your last shift are some of the most important, most commonly done things? And so you can imagine that things like washing your hands is going to show up a lot. Checking 2 patient identifiers, those things are really important and they're done all the time because they have to do with patient safety. Whereas something like postmortem care, although that might be done, that might be one of our responsibilities as nurses, it doesn't require as much clinical judgment, and ultimately it's not as high stakes if something goes wrong. So that's what the NCLEX is going to focus on, is stuff that you need to know in order to keep your patients safe. And so actually the top 5 client need areas on the NCLEX make up over 70% of the exam. So in a typical 100-item NCLEX, you're going to have 25% or a quarter of the exam made up of clinical judgment items. So those are items that are going to show up in your case studies as well as bow tie questions that ask you to think like a nurse and apply the nursing process. The others are going to cover management of care. So those are your prioritization, delegation, assignment items. Pharm, everyone's favorite subject. And physiological adaptation, this is going to be your nursing process for all different kinds of disease processes. And finally, safety and infection control. And so we are going to focus our time on clinical judgment today because, again, NCLEX Bootcamp likes to focus you on the most important aspects. But we aren't going to leave you hanging for the others. We actually have brand new cheat sheets available. And if you guys stay to the end, we're going to get you a link for these. They're like a cheat code for the NCLEX. And so we've got our prioritization cheat sheet with a prioritization pyramid here that's going to help you understand kind of how to prioritize between clients, as well as our delegation and assignment cheat sheet and many others for you to look at. So, all right, to start, we're going to look at the clinical judgment measurement model. And this is the 6-step process that outlines how a nurse thinks. And this ultimately parallels the nursing process roughly, right? So you guys are familiar with ADPI, and this is not so different from that, where first we recognize cues or assess what's most important, then we analyze what they could mean, we prioritize among those hypotheses or figure out where we start and what we can do about it, then we actually take action to correct it and evaluate to figure out if it helped. So, all right, we are going to look at several items from our bank that test different steps in this clinical judgment process. You're typically going to see these on the NCLEX in the form of case studies, but just for the sake of time today, we're going to look at a couple of these in the form of standalone items. So I don't want to give away the answer on the next screen. So I'm going to actually ask you guys, comment what your most difficult subject is. We might give future webinars on it. If enough of you say that it's your challenging subject. So let us know, what content area do you struggle with the most? There we go. All right, back to it. So next gen case studies are typically where you're going to find your clinical judgment items, and we're going to look at some standalones. So the first question in a case study is going to ask you your ability to recognize cues, and that's to figure out what's most important. Because you guys know that as a nurse, you always have like 10 things going on at one time, right? Your patient has 5 things in their medical history, they have 4 medications due, and they're on their call light, and the person next door is getting out of bed. And so it's really important that as a nurse, you can figure out what in the moment is most important. So we're going to pick from which of these assessment findings are most important. So here we've got a client with severe COPD, or chronic obstructive pulmonary disease. Which of these findings is going to require immediate follow-up? And so remember, on the NCLEX, if you are asked to select what requires immediate follow-up, you are looking for an unexpected abnormal that you need to do something about, right? So we're going to have all kinds of abnormal findings that are expected. And so we want to make sure that we're prioritizing those unexpected abnormals. All right. And so what do you guys think? And we're going to do a quick review while you guys think about it on what COPD is. So in COPD, you can have either chronic bronchitis or emphysema, or both. And so in chronic bronchitis, you have chronic damage from an irritant. And I bet you guys can remember what the #1 irritant is that causes COPD. So what's that? Type it into the comment box. But in chronic bronchitis, that irritant damages and inflames the bronchioles, and that causes this inflammation and narrowing of the airway, so you can't get air in. And then in chronic emphysema, you've got destruction to the alveoli. So instead of this alveoli being like a really nice stretchy balloon right out of the package where it deflates and all the air exits smoothly, instead it's become like a floppy plastic grocery bag. And so when the client exhales, this just kind of collapses in on itself, and that is going to prevent the air from getting out here. All right, so knowing this, which of these findings would require immediate follow-up? How about 1, lower extremity edema? So why would somebody with COPD have lower extremity edema? What complication of COPD would cause that? Okay, everybody's liking 2 as an answer. Very good. Okay, smoking, you guys got it. Excellent. All right, why would somebody have edema? So do you guys remember what, okay, good. Florabelle's got it, heart failure, yes. So, and yes, you guys even got it as right-sided heart failure. Really well done, Marissa. So in COPD, this chronic kind of high pressure system in the lungs can put strain on the heart. And so yes, that can cause some right-sided heart failure. Now, does that require immediate follow-up? It might, right? Heart failure might. So if I had signs of pulmonary edema, like pink frothy sputum or restlessness, that would require immediate follow-up. But what would you even do about the lower extremity edema? You would probably just prop their feet up, right? So this isn't something that I need to immediately follow up on. So it's not this one. We'll just keep an eye on it, prop their feet up. All right, paradoxical respirations. Several of you guys liked this. And I mean, liked it as the correct answer, not liked it in your patient. But yes, paradoxical respirations is never normal. So this is not an expected abnormal finding. This is something I'd like to keep an eye on. So in paradoxical respirations, instead of the normal rise and fall of the chest when you breathe in and out, it's inverse, because your patient is sucking in the breath and having to work hard to push it out. And so this is an indicator of a really, really high work of breathing, and this patient is getting tired. And so I immediately want to follow up on this, I'm pretty sure, but let's look at our other options just to be safe. So an increased hemoglobin level, is that expected or unexpected in COPD? What do you guys think? So why would somebody with COPD have an increased hemoglobin level? And that is because of something called polycythemia vera, right? These clients have chronic hypoxemia. They chronically have a low blood oxygen. And so, in an attempt to kind of compensate for this, your body starts to produce more and more red blood cells in order to try and carry more oxygen around through the body. And so, that is going to create an elevated hemoglobin. Good. Everybody's saying this is expected, right? So, I would just monitor this. There's nothing I want to do about this right now. All right, then in a pulse oximetry reading 88%. Do you guys remember what the normal pulse oximetry reading is for COPD? Yes, good job, everybody. You said no, you don't remember. All right, so the normal pulse oximetry range for COPD is 88 to 92%. So there's nothing I would need to do about a pulse oximetry. Yes, Floribel's got it. There's nothing I would need to do about this. I would only need to increase their oxygen if their pulse ox was 87% or lower. So out of all of these, the only one that requires immediate follow-up is this paradoxical respirations. And remember this key term for the NCLEX, you guys, because this is never normal. They might give you this finding in a patient with asthma. They might give you this finding in a patient with rib fractures, right, and a chest wall trauma, but it is never normal. It's always going to be a warning sign of impending respiratory failure. So very well done, you guys. And yes, you can see in our question bank that only 57% of our users answered this correctly. So if you guys got this one right, you are already ahead of the curve, and well done. All right, so after we recognize cues, we're asked to analyze those cues or figure out what could they mean. And so a really common way that the NCLEX loves to do this is they love to ask you to distinguish between chronic venous problems and arterial problems. And so in this case, we've got a client with chronic venous insufficiency. Which of these findings is going to support that diagnosis? And again, they love to make sure you know arterial versus venous. So let's do a quick review. All right, so in peripheral artery disease, well, I'll ask this. If you guys had to choose one, neither of them are good, but if you had to choose whether you had peripheral artery disease or chronic venous insufficiency, which one's worse, so to speak? And I hope you guys all get this right. But between the two, I think I would personally prefer to have venous insufficiency because with peripheral artery disease, you have a lack of blood flow. You don't have enough blood getting to the distal extremity. And so in peripheral artery disease, you've got this atherosclerosis, also from smoking, you can cross this, and that's going to narrow the arteries and limit the blood flow down to the distal leg. So you're going to have these findings of arterial insufficiency. And so basically that's where your 6Ps come in. You have a pale extremity with weak pulses. It's got pallor, pain. They're going to cramp when they walk because it uses up all the blood in the leg. Good. Whereas in chronic venous insufficiency, we've got valves that don't let the blood return smoothly and it starts to pool in the lower extremities. And so that is going to cause signs of fluid retention. So you're going to have swelling, heaviness. When you do get ulcers, they're going to be higher up on the leg versus in peripheral artery disease, the problem is going to be worse distally on the leg. So in artery disease, you've got ulcers on the very end of the foot, the toes, and in chronic venous insufficiency, they're typically higher up on the calf or the shin, right? So, all right, let's consider absent pedal pulse. Let me know, you guys, is that an arterial finding or a venous finding? Is that a problem related to PAD or chronic venous insufficiency? And I see you guys all kind of like 1 and 4, so this is something that you guys might struggle with. All right, so if you've got an absent pedal pulse, that means, yes, Floribel, again, you're right. We are not getting enough pulsatile blood flow to the foot, and so we're not feeling a pedal pulse. So that is not consistent with chronic venous insufficiency, so it's not this one. Then intermittent leg cramping with exercise. Is that an arterial or a venous problem? So this could happen with either if they're severe enough, but really, intermittent leg cramping with exercise is called intermittent claudication. And that's where the patient's walking around, their calf muscle uses up all the blood that's already there, and then it runs out because we can't get enough blood fast enough to that extremity and it starts to cramp. So that is also an arterial sign. Good. Then ulcers on the toes with well-defined edges. Yes, you guys are right. Again, that is an arterial problem. We are not getting enough blood flow to the foot. And so down here on the toes is where you have arterial ulcers versus higher up on the leg with venous ulcers. Good. So this is also an arterial problem. And the last one then is what we're left with, which is brown discoloration to the lower extremities. And have you guys ever seen this before? It's something called hemosiderin deposits. And I like to think of this like the leg is rusting, kind of, right? Because we've got this blood just pooling down here. It's stagnating here. And what's in blood but iron, right? And so we have iron that actually leaks out of the vessels into the skin and kind of sits there and oxidizes and discolors just like rust would on something that sits around. And so that is going to be typical of chronic venous insufficiency. Very well done. And again, only about 50% of our users got this correct. So if you guys answered this correct, you guys are ahead of the curve. Well done. All right, so next, now that we've analyzed what those cues mean, we're going to prioritize hypotheses or figure out where do I start. And I've got another question for you guys. So we're going to prioritize in a hypothetical situation where you are the neuro ICU nurse and you've got a patient who just had a craniotomy and they're coming out of the OR. What are you prioritizing monitoring for? What complication are you most worried about after a craniotomy? There's several things, right? After any surgery, we're going to worry about bleeding and infection. That's obvious. They're going to come out on the ventilator, so they're already going to have a protected airway. But there's one complication. Floribel's got it. Increased ICP. Tenzin, I remember you from last week. Yes, an increased ICP, correct. So that's our priority in this patient, and we need to figure out, as we're monitoring for that, someone who's at risk for increased ICP, which of these assessments does the nurse prioritize? And I'm going to let you guys answer this one. Is it the Babinski reflex, the presence of a headache, the pupil size and reactivity, or the level of consciousness? Again, we are going to be doing all of these assessments, but what do we prioritize when we're monitoring for an increased ICP? Tenzin says 4, level of consciousness. Okay. All right, you guys are liking 4. I am too, but let's talk about this. So the Babinski reflex, that is actually an assessment for spinal cord reflexes, right? We are going to be assessing this in this patient because it's part of our neuro exam, but that's really going to tell us more about their spinal cord function instead of ICP. Good. Presence of a headache. So would you have a headache with increased ICP? Those of you who didn't choose this one, would you have a headache as a symptom of an increase in ICP? And the answer is yes, right? You would. You would have a headache, but you would also have a headache because you just had brain surgery, right? And so that really doesn't tell us anything. This doesn't tell us that a complication has developed. It could be totally normal. So that one is an assessment, but it's not going to be the one that we prioritize. Then pupil size and reactivity. Yes, you're going to see pupil changes, but that is a late sign of increased ICP. So you're going to see pupil signs, but I'm not going to prioritize that because the first thing I would see is going to be a change in the level of consciousness. Do not forget this. It's a big NCLEX tip. Your level of consciousness is your earliest and most sensitive indicator of increased ICP. So if you see them getting drowsy, confused, you can't wake them up, you need to immediately notify the healthcare provider and get ready to take them back to the OR and place a drain. So very good. You guys, I'm happy you all got this right because 80% of our users did. So this is one of those need to know things for NCLEX. Well done. All right, so generating solutions. Now we've prioritized what we're considering doing. We need to figure out what can I do about it. And for this one, we've got a select all that apply, everybody's favorite. And so in this case, we've got a client who just had a coronary angiography and it was via a femoral artery approach. And so which of these interventions do we anticipate including in the initial post-procedure care? Select all that apply. So here's a tip for select all that apply on the NCLEX. You want to treat each option as if it's its own true or false question, okay? So let's do a quick refresher on what a coronary angiography is. So here's a picture of one being done. And what is this done to treat, you guys? So what condition is a coronary angiography done to treat? And there are a couple, but the number one big one that we should all be familiar with is this is your emergent intervention for a STEMI. And that is because what we do here is they're actually going to give a puncture here into the femoral artery and thread this stylus up. They're going to inject contrast dye to visualize under an x-ray where the blockage in the artery is. All right, you guys have some, yes, MI, CAD, yes. So that's treating this, and that's going to help them visualize that blockage and stent it open. All right, so which of these interventions would we do? So true or false, we should place the client on a fluid restriction. And the NCLEX would love to ask you this because they think you're going to confuse this with a heart failure patient where that might be appropriate. But there's one organ that hates IV contrast more than any other organ. Which organ is that? That we gave a ton of IV contrast in this study. We injected a lot of contrast dye, and there's one organ that really hates IV contrast, and that is your kidneys, correct? Good. So this person is at high risk for contrast nephropathy or acute kidney injury. And so what we have to do for that is we have to give a lot of fluids to flush out that contrast. So we need to give a lot of IV fluids, or if they're taking oral, a lot of oral fluids. We are not going to put them on a fluid restriction. That would be more appropriate for someone with heart failure. Good. All right, are we going to monitor the puncture site for swelling? And I see that several of you chose to, and yes, that's true, because we just gave this person, in the case of an MI, a ton of aspirin, a ton of heparin, and then we made a puncture in one of the largest arteries in their body. So they are at really high risk for bleeding, and we're definitely going to, every 15 minutes, so 4 times an hour, go in, pull back their covers, look at their groin site, and make sure they're not developing a hematoma or like this big tennis ball sized bruise there. So this is definitely appropriate. Good. Are we going to place the client on continuous cardiac monitoring? And yes, of course we are. This is one of the first things we should do. They should never even leave the cath lab without this on the bed with them, right? Because we just went in there and kind of tickled the heart. And so they're at high risk for dysrhythmias, or if that stent occludes, they could start to have some ST elevation again. And the only way that we're going to see that is if we have them on the monitor. So yes, we need to do cardiac monitoring. Next, should we assist them up to the chair to prevent atelectasis? And this sounds like a good idea because we want to prevent a complication, right? We want to prevent somebody from getting atelectasis. And there are several ways we could do that, like our turn, cough, deep breathe exercises. But in this client, should we get them up out of the chair in the immediate initial post-procedure care? Gary's Joy says no. Anne says no. You guys are right, because these clients, remember, need to be on strict bed rest. So they are on bed rest for usually 4 to 6 hours. They've got to stay completely flat. And that is important because that groin site here, this injection site, if they bend at the waist, if they cough too hard even or bear down, that's going to put a lot of pressure down on this site and going to risk hemorrhage. So they have got to stay totally flat for 6 hours. And really, they're not at that high of a risk for atelectasis anyway, because this is a short procedure, like maybe an hour and a half. All right, palpating the client's bilateral pedal pulses every 15 minutes for the first hour. And I think you guys understand now that we are worried about bleeding in this patient. And this is going to be helpful to us because we want to make sure that this blood is traveling from the heart down to the extremities and not leaking out into their abdominal space or into the leg. And so the only way we can really tell that is to look at the groin site and to go down at their feet and feel and make sure those pulses are equal. So you might see maybe you're assessing somebody on the NCLEX after an angiography and they have a weak pedal pulse on one side. That is an emergency. We need to worry about that because that means they're not getting as much blood as they should past that insertion site. All right, so awesome, you guys. Our users averaged about 80% on this, so this is important stuff for you to know. And remember, the Bootcamp question bank is all completely up to date with all the next-gen scoring rules. And so anytime you get a SATA question and partial credit, you're going to get the scoring rule for that as well to help you out there. All right, good. We're almost done. So next, we're going to take action or decide, what will I do? And here we've got a pretty high stakes situation. So we review the diagnostic results for this client who's unresponsive and has no palpable pulse. We observe that they've got gasping respirations. And then when we look at their EKG, we see this. So what is you guys' interpretation of what's happening with this client? I'll let you kind of, if you think you know what rhythm interpretation this is, you can leave it in the chat box. But everybody kind of consider, which action do I take? Do I initiate chest compressions, give IV push atropine, get a 12-lead electrocardiogram, or deliver rescue breaths with a bag valve mask? And I see everybody is selecting one. Okay. Does anyone know what? No one wants to tell me what their rhythm interpretation is. Okay, Joy says asystole. All right. Florabelle says PEA. Okay. All right, 1 and 2. Okay, so let's talk about this. I've got a sinus Brady, 3. All right, any of these would be actions that I'm eventually going to want to take, but I'm going to give you a hint. The only piece of information that you need to answer this question is right here. No palpable pulse, right? If they don't have a pulse, it doesn't matter what the EKG shows. Nothing else matters. If they don't have a pulse, they don't have a heartbeat, and we need to initiate chest compressions. And I think a couple of you got this correct, where yes, our EKG shows a rhythm that looks like sinus bradycardia, but if we don't have a pulse, that just means all this is electrical activity. There's electricity moving from the heart, but it's not actually generating a heartbeat. So we need to immediately initiate chest compressions, high quality chest compressions, to start pumping that blood through the body. Yes, but why might we have fallen for these others? Okay, IV push atropine. That would be for bradycardia with a pulse, because in that case, there's no issue. The electricity is generating a heartbeat, just not fast enough heartbeat. So we give IV atropine to speed it up. All right, obtaining a 12-lead electrocardiogram. Again, we don't really need that information. It doesn't matter what it shows. It could show a perfect sinus rhythm, and we would still give chest compression. So this is not going to be so useful. Then delivering rescue breaths with a bag valve mask. This might be helpful for someone who has gasping respirations and a pulse, like in the case of an opioid overdose, where we just need to give some rescue breathing. But never forget, pulseless client, chest compressions. And don't be afraid to do it, you guys. At some point in your nursing career, you're going to be the person to find a patient pulseless, and you need to jump on those chest compressions, because every moment that you wait, their brain tissue is dying. So please remember this. And again, only about half of our users got this right. So you guys don't forget this. Pulseless patient, chest compressions. Well done. Okay, then finally we evaluate outcomes, and we look at everything we did and decide, did it help? And so that might be in the case of an intervention, a medication, or we're going to look at one where we're trying to see if our teaching was effective, or if the patient learned what they were supposed to in our teaching. All right, so in this case, we've got a client who's scheduled for a total laryngectomy. And even if you don't know what a laryngectomy is, you can kind of pick apart the word here. You know, ectomy is the removal of something, and the larynx is your voice box, right? So, okay, which of the following statements by this client would require follow-up? I'll have to practice using a mirror to care for my stoma. And remember, in our larynx here, this is going to leave them with a stoma on the front. And so, yeah, it's very important after they have this surgery and there's a lot of body image changes, they need to learn to care for it themselves. And so they can do that with a mirror. And yes, so is that going to require follow-up, or is that an appropriate statement? All right, I see you guys answering. Everybody likes 2 and 4 as an answer. Okay, so we'll get to those in a second. But remember, when the NCLEX is asking you what requires follow-up, you're looking for something that they've said wrong, something that's incorrect that we need to correct them, or better yet, get the healthcare provider to come correct them about, right? And update their teaching. So it is correct, and we don't need to follow up, that they should use a mirror to care for their stoma. All right, when I'm discharged from the hospital, I won't need the feeding tube. And this is not removal of, the tongue. This isn't anything where it should affect their swallowing. They should be able to eat and drink on their own. And yes, y'all are right. This is an appropriate statement. So that is correct. How about this? My husband has brought me some scarves to wear loosely over the stoma. Is that okay? And so, yeah, this is fine, right? As long as we're not tying like something dirty really, really tightly around the stoma, this should be fine. Again, they're going to have a lot of body image changes. And if this is what they need to do to cope and adjust to their new body image, they should be taught that that's safe to do. So yes, this is fine. All right, so that leaves us with this. After the surgery, my voice will be hoarse, but eventually return to normal. And so you guys, a lot of you selected 4 because, right, they will never have a normal voice. They don't have a voice box anymore. So we might be able to help them get a voice prosthetic where they can occlude the airflow and instead it goes out through their mouth and creates this kind of robotic voice. But right, they are not going to have a normal voice even after recovery. And it's important that they understand that going into the surgery. So we would want to follow up on this one. And less than half, 41% of our users got this correct. So remember that, you guys, after laryngectomy, scarves are okay. They're going to be able to eat and drink okay. They've got to care for it in the mirror, but they will not have a normal voice. All right, so great job, everybody. Thank you all for hanging on to the end. Sorry about our technical difficulties there at the beginning, and I'm glad that you guys all hung out. Again, we love having you here. We love answering your questions, helping you think through how to think like a nurse on the NCLEX. So please give us a follow here on YouTube, like, subscribe, hit the notification bell. We would love to continue to help you guys prepare for the NCLEX. We're going to be coming back every week for these. And don't forget to go ahead and check out our free NCLEX cheat sheets. Check the comment box for the link for those because we are going to give you free NCLEX cheat sheets and a 10% discount for hanging out with us today. So you guys are so welcome. Thanks for hanging out and happy studying, okay?